Hey, watch it. Yeah, whatever. Hey, this is the only time I'm up here, so there. I'm down now. Okay, we can have a stash contest. Yeah. So, over the next hour or so, we're going to do 12 leads. Yahoo! Right? Oh, yeah. We're going to speed read a little bit, too. We're going to move through them fairly quick because you need to be able to look at them and not have to stare at them for a long time and write down a bunch of crap. You need to be able to look at it and start thinking about what it really is. So we're going to do that a little bit. I'm not saying we're going to do a 10-second drill or something, but I'm saying we need to look at them fairly quickly and start making some decisions. I'm going to review a little bit about how to do a 12 lead and what some steps are. Some steps. This isn't the only way to do a 12 lead. This is the way I'm going to teach you how to do a 12 lead, okay? Your EMT is going, why do I want to do that? Because you can, all right? And what you do whenever you're taking 12 leads is very important as well. So we're going to cover how to do it as well as reading them, okay? That work? All right. I know a bunch of you are getting taken out for testing, or for, it's
not testing.
What is it?
Scenarios.
Sorry. I was using the wrong word. I knew as soon as I said it, I was dead, okay? I was dead in the water. I'll be beaten about the head and shoulders by all people who are leading scenarios. So anyway, we're going to go over some of these. I've got probably 40 or 50 EKGs to look at. We'll talk about them a little bit, but we're going to do the steps and things first. He's going to take some people out. It is being recorded, so you can go back to this whenever you need to.
2 months.
Starting right off the bat, we put a lot of patients on EKGs, don't we? Some of them we do 12 leads on. How do you decide which ones to put a 12 lead on? The ones I want to. Okay. All right, almost. All right, it's a beginning. So what else? What things tell you? What are the alwayses? Okay. Chest pain. CVA. Okay. All right. Yeah, and you remember CVA, right? That we do it for that as well. Okay. And so there's a lot of patients that we may do that to. Then there's the subtle patients that we may put on it as well, and it's anybody that we feel may have some sort of cardiovascular involvement or somebody that we can't figure out what the heck's going on. We certainly need a monitor on them, and then we need to take a little bit closer look at them and see whether or not we feel like, gee, should there be a 12 lead? If you do a 12 lead, medics, if you do a 12 lead and look at it and don't see anything, can you hand this patient off to an EMT? I don't think that's a very good idea, okay? I think that's a sucky idea, as a matter of fact. And EMTs, I'd tell your medic that you were driving, you know? I'm going to shut my phone off now. Okay. So, when you put a monitor on, where do you put the patches? Where do you put the first 4 patches? Limbs. So somebody put up their wrists. Other people, where else? On ankles, right? Wrists and ankles. Where else can we do it? If you do that, what's the problem with doing that? What's the problem with wrists and ankles? They move, and we get a lot of artifact, right? Okay. So what can we do to fix that? Arms, legs. Arms and legs. You can do arms and ankles, but you can do arms and up to the thigh. I don't know that it'll actually make any difference. I probably wouldn't put one on a shoulder and one on a wrist, right? One on a thigh and one on an ankle. I think you ought to go kind of the same height. Are any of you still putting them on the abdomen? Depending on the size of the patient. What's the size of the patient got to do with it?
Well, if my leads are going to be, I guess if I do it upper
Yeah, so in a way, but it does happen once in a while. The problem with it is there's a whole lot of people that don't know that it has to be outside the midline of the clavicle, outside that, and below the belly button. Now, some people's belly button is down a little lower than other people's belly button. So really what we're talking about, you really ought to be probably down onto the pelvis, down to the pelvis area, or just go ahead and go to the legs. Go to the legs. So part of it has to do with how much is your patient cooperating and how much is your patient, do you need 911?
No, I should
Yeah, okay. So you may just, but if you'll do arms and ankles at least and not come inside that, that is the best, okay? If I have a patient that's really not cooperating at all and I have to move into the chest, don't come in any further than just outside the midline, okay, for the arms. That's really not desirable, but it is doable, okay? Especially if you're doing a 12 lead. When you're doing the 12 lead, we really kind of need to get out to the arms. Do I care that you get clear to the ankles and wrists? No, I do not. There are people that teach that you have to do it that way, but we do not just have to do it that way. The cardiologist, Dr. Caesar at Cox, has given, he says, honestly, I can't tell the difference when it's on the arms and the thighs. Okay? So that's from the cardiologist. That's the only reason I keep repeating that, is because that came from him. All right? So then let's talk about, and so how many leads can I get off of these four? How many readings? Keep going up. Yeah, no, not really. Not quite. I get what you're saying, but not quite. Huh? 6. 6. I get 6 leads just off of the arms. Okay? Just off of the arms and legs. All right? So lead 1. Okay, so there's bipolar leads and there's unipolar leads. How many leads are in a unipolar lead? Yeah, 1. All right? How many in a bipolar lead? Yeah, watch. I'll give you answers, okay? I know you knew that. But, so here's the deal. We used to use paddles, right? Older medics will remember this. How many of you used paddles? Seriously? Oh, dear God. Yeah, come on. All right, all right. This is scaring me. This is scaring me that there's not many of us left, okay? So with paddles, we would put a negative one in this hand and a positive one in this hand, right? Okay? And you go, this is lead 1, this is lead 2, and this is lead 3. That's how I learned to do the first 3 leads, okay? Why did I learn to do that with paddles? Because you're not in asystole in one lead. When we walked up to dead patients, we went 1, 2, 3. And you saw them in 3 leads. And if they're all asystole, okay, make sure that your LifePak 5 was hooked together so that it was, you know, really a monitor. So, okay, it's an inside joke for about 3 people. I'm sorry. So now what we're doing, though, is understanding those are bipolar leads, and those 3 are the only bipolar leads. So they read what's between here and here, between here and here, and between here and here. Negative, positive, negative, positive, negative, positive. Okay? That was the 3 leads, 1, 2, and 3. Then, out of these 4 wires, again, we get 3 more leads. All right? So we have AVR, AVL, and AVF. Okay? AVR comes from here. It's the positive lead, and it's only a positive lead, and it absorbs electricity from the entire globe around it except that when it's hooked to my arm here, it really only gets it from my body. And electronically, the monitor says, ooh, we're going to tell you there's a central spot right here in the middle of my heart, okay? That is the negative lead. So it's reading only from just right there. So it's reading down here, okay? Ooh, we do have a blackboard. You shouldn't give me a blackboard. That'll be, I might use it. I might use it. Okay? So now I'm reading here. The left lead in my left arm, unipolar lead, is AVL, and it's reading from here to the center of my heart. Okay? And there's another one that's coming from my foot to the center, and that's AVF for foot. Okay? It's really complicated. AVR right, AVL left, and AVF foot. Okay? They did that for doctors. Okay? All right. So now we have 6 leads. We have some going across this way. And it becomes important because it has to do with axis. Yuck. All right? Has to do with axis. So I have one that's reading across my heart this way, one that's reading across this way, one that's reading across this way, and then another one, AVR, is coming from a little bit more of an angle over, and AVL is a little more angle over, and AVF is from straight up from the bottom. Okay? What it turns into is a clock. It's all just one big clock. All right? In fact, I could even call it a compass. And the reason I call it a compass is because remember the degrees that it says the QRS is in some degrees? It says 90 degrees, 60 degrees, whatever. It's the compass. The weird thing about the compass is that 0 is out here, not up at the top. 0 is out here. So from here straight across my heart is 0 degrees, and that's lead 1 looking in, positive, and negatives out here on this side. Okay? Positive, negative. So it went from 9 o'clock to 3 o'clock, or 3 o'clock to 9 o'clock from your side. Okay? You'll have to correct me on the time here. All right? And lead 2 is from 60 degrees. So I move down 60 degrees to, what is that, 5 o'clock? Yeah? Right? I think it's 5 o'clock. Move down to about 5 o'clock and comes up. And that is lead 2 coming up, and it comes right out up here off my shoulder. Okay? So the negative's up here. The negative's up on this end. So you're just looking at this clock around here. The whole thing all matches up to a clock. Right? Lead 3 comes from 120 degrees over here. So I had from 0 to 90. So I worked 30 degrees back this way and 30 degrees this way. All right? So here's lead 2 from here, and lead 3 is coming up here. Those were all positives that came off the foot. But you have to understand that the monitor is electronically making adjustments here, okay? Because lead 3 reads from this arm out over here down to my foot. So there's an angle there. Do I expect you to remember this? Nah, not really. But you need to just understand, I'm getting 6 views of the heart just from those 4 wires, okay? So they need to be put on right. Now, and so all of them are looking at the heart from this angle here, okay? The next 6 are going to look at the heart from this angle here. Each one of them from the positive lead, so red's not always positive, by the way. It moves electronically. They did white, red, black, and green for us, for doctors. Let's put them down while we're at it, okay? We could have figured it out. But they do that for us so that it's easy to put them on, okay? And so once we get all of these on, and we're looking in. Each of the positive leads is looking at my heart from a different view. Okay? And then I have 6 more leads coming from here, from this angle. So 1, 2, 3, 4, 5, 6. They're all looking in these angles. Can you see that V5 and 6 and 1 and AVL kind of look from the same area? They look over here at this part of my body. Well, what would I call this part of my body besides left? No. Well, yeah. But what would I call this part of my body? Just lateral? Lateral? Okay. So we had to get to the right set of terms. It's okay. All right? It's okay. I'm not going to beat you up for it. All right? So I have lateral. What part of my body is this? The anterior side. So there's actually 4 leads up here in the anterior part of my body that they're all looking at anterior. Then 5 and 6 are looking lateral. Okay? It's just that easy. That's all it is. So I'm going to take an apple, okay, my imaginary apple here. And I got a bite out of it, okay? And I got, the bite is facing me, okay? The bite is facing me. How many of you can see the bite mark? You can't, can you? Because you're on the other side. But the leads that are out over here can see that bite mark. Only some of, yes. Yes, you can. Because the bite mark's over here on this back side. That's why we have leads that look from all these different angles, and we're looking for one thing from those leads to find a what? What's the only thing we're caring about with this particular 12-lead class? STEMIs. We only care about STEMIs.
We get team 3s and the rest of the team 2s. People always walk out.
I know. They always walk out on me. It is why he's here. It's exactly why he's here. Okay? So the part of the heart that lost circulation is the same part that I took the bite out of the apple. Only some of them can see it. Some of them cannot. Okay? If I take a bite out of the right side of the apple, none of them can see it. Okay? And that's why we have extra leads that we put on as well, V4R and the leads in the back, V8 and V9. That's why we do a 15 lead. How many leads can we actually do? I'll answer your question in just a second. How many leads can we actually do? 18 at least. And if we really wrap around all the way around here, we can do 24. Okay? It's crazy. Well, I got to tell you, the 24 lead would be a little bit odd for them, but you know, why not? Let's do it. Let's do it. Yes, ma'am. Why don't we do 15s? Because you don't always need them. So which ones do we need them for? Let's talk about that. You brought it up. Let's talk about when do we need a 15 lead? That's when you do it. That's one of the times. That is one of the times you do it. Well, not necessarily. Which patients is it contraindicated in? Inferiors. Inferiors. Okay. Who is it really contraindicated in? An inferior patient is not really by itself the actual contraindication. We don't because of the potential of what an inferior does. The real problem is the right-sided infarct that I have no leads looking at. I honestly only care about a 13 lead. I don't care about V8 and V9. That's Dave Hoover. You don't have to take that to the bank, okay? We do 13 leads because I want this one that looks at the right ventricle.
And you can just move that one and do it?
Yeah, just take V4 off and put it in exactly the same spot on the right side. And that will tell me about the right ventricle if it has ST elevation in it. Okay? That's all I really have to do. Now I'm going to tell you why, because I was taught by a nurse that was ancient when I was young and taking it. Okay? and so there's a gazillion years of experience that's not mine that's coming back here to tell you that. Because I can tell you a great deal of the time, not all the time, how to find a posterior from looking at the front. Okay? Tell me what a reciprocal change is. Tell me what a reciprocal change is. I'm repeating everything you say so that we get it on tape. So, yes. What is a reciprocal change? Yeah. So if I have elevation on one of the eyes looking over here, then one of the eyes looking on the opposite side will see depression. Because it's just essentially a magnet. It's negative on one end and positive on the other. It depends also how significant the damage is to the heart. If it's full thickness, I'm going to see more reciprocal changes. All right? So remember the teeter-totter? Did you do a teeter-totter with reciprocal changes? Right? So here's the reciprocal changes. 2, 3, and AVF. Okay, all the leads that come from down here, all right, because my foot is always positive in all those leads. 2, 3, and AVF, they're on one end of the teeter-totter, and everything else is on the other end of the teeter-totter. 1, AVL, V1 through 6. If 2, 3, and AVF have any elevation, then I look for depression in any of the other leads. If any of these leads have elevation, then I look for depression in 2, 3, and AVF. Is that a flat rule? No. Okay? It's a general rule. Okay? Everything I tell you will be pretty much a general rule. All right? So that's where I'm looking for. So 2, 3, and AVF, and the other leads we're going whichever way. All right? Whichever one goes up, the other one goes down. V1 and V2 are looking at the anterior portion of the heart. So what's behind anterior? Posterior. All right? So if I see depression in V1 and 2, what do I got in the backside? I may have elevation back there. Okay? So it might be ischemia in the front, but it might be an MI. If you've got depression here in V1 and 2, you absolutely ought to put some leads in V8 and V9. Okay? We absolutely ought to put it on V8 and V9. And that way, you can have, nobody can condemn you for not doing a 15 lead. Okay? But if you're going to do those, you got to do this one too. Because this right ventricle infarction is what's going to get you in trouble. That's what gets you in trouble, not the posterior, not the inferior. It's this one. Why is that? Because of the circulation of the heart. The RCA, the right coronary artery, comes from the aorta. It goes across, feeds your atria. It feeds your SA node in some percentage of people, and it feeds the in some percentage of people. I'm not going to do all that, okay? See, it feeds the AV node in like 85%, something like that. So it comes around, and it feeds the right ventricle. And then it comes around the back, and it feeds the posterior portion, and then it drops down to the inferior portion. Okay? The right ventricle does not have very thick muscle. And so it has an MI less often because there's not as much blood supply going to it to feed it because the muscle's not as thick. The left side, the LCA, the left main, divides into the left anterior descending. That comes down, and on like 60% of people, or 85, and honestly I don't remember which, it's one of the two. We can look it up if it's important to you. goes down underneath the inferior portion of the heart and feeds the inferior portion. Well, so does the RCA. And we call that what kind of circulation? Collateral circulation. It comes from two sources. Okay? But on a certain percentage of patients, if you have an infarct in the LAD, it also gets the inferior. In another certain percentage, if you have inferior, it came from the RCA, the right coronary artery. The problem with that now is, if I found it on the end of the hose, on the end of the RCA, how far up is the blockage? I don't know. So that's why I want to check this over here. All right? So if I'll check for a right ventricular infarction, and I take their blood pressure, okay, and I got a good blood pressure, and I don't find anything on the right ventricular infarct, is it more safe now to give a nitro? Yeah. What should I still have ready first? A giant IV. Not an IV, a giant IV, okay? And the thing that always scared me from the cardiac nurses, they'll give somebody with a right ventricular infarct 2, 3, 4 liters of fluid and not even think about it. We'd shoot ourselves before we do that, okay? Because we think we're going to kill the patient. But it's a right ventricular infarct that's doing that, because you still have to have enough blood coming in for the heart to have refill so that it can have blood flow. That's where your blood pressure goes. All right? So we can give the patient with a right ventricular infarct more fluid and not be too afraid of that. That's a dry lung problem, dry edema, so as compared to wet lungs, that because of the left heart problem. Left heart failure is going to give you wet lungs. Right heart failure is going to give you dry lungs. Okay? That makes sense? Follow that? Some of you are going, really? Yeah, you're killing me. It's all right. Stick with it. We're going to do some stuff. Yes?
Just as a note to the people that aren't here, if you do take a right or a 15, you can document that, especially in healthy MS, and so you don't lose track of your papers, put a big R or a big 15 written on it to give to the doctor.
Yeah, and so when you do that lead, what we're really saying is that V4, you got to put that big R beside V4. And you're going at V5 and 6, you're going to put 8 and 9 on them, and you have to know which one's which. Okay? So the entire right side of the screen, you must absolutely ignore anything the monitor says now. You absolutely must ignore it, because it is totally confused. Because it thinks you're giving it V4, 5, and 6, and you're not. You're giving it V4R and V8 and V9. It has no idea what's going on.
So when you write the letter, also scratch that out so they don't get excited.
Well, yeah, that's probably a decent idea. Just exit. Now, don't scratch things out, right? That's a medical no-no. We'll put lines through it, initial it, whatever, okay? Don't do the medical no-nos. But yes, you're exactly right, Freya. That's exactly right. Okay. So, where are we at? We've got enough confusion here. Let's read some 12 leads and make it easy, okay? So when we're reading 12 leads for a STEMI, what are we looking for? We're looking for ST elevation, and we're going to talk about where is that point that we begin to look at it, okay? Can you measure a QRS? Are you able to measure a QRS? Where you stop measuring the QRS, right, on the right-hand side of it, that's where we measure for the ST segment, okay, for ST elevation, all right? That's the point that we do it at.